I'm Ben. I'm the creative director here at Sketchy. I graduated from med school back in 2018. Did my first year of urology residency out here in LA at UCLA, but ultimately realized that I did not want to place Foley's for a living, and I did want to make cartoons. Quickly, my craziest rotation story was on a trauma surgery rotation. We had a patient come in after getting hit by a car, and anyway, long story short, he decompensated in the CT scanner. We had to do an ED thoracotomy, so we had to crack his chest open in the emergency department, which is sort of a high-risk procedure, as you can imagine. And it was one of those like crazy moments where the chief resident was beating the guy's heart with his hand, and then he had to place some sutures, and the resident's hand was shaking so much that he couldn't throw the suture and then grab it with his pickups. So I had to take his needle and pass it back to him, which is certainly a non-standard surgical procedure. So yeah, a memory that will definitely stay with me.
And hello, everyone. I am Seth Politano, Dr. Politano, or Dr. P, as my students and residents call me, just to make it easier. I'll go through a little bit of my journey like Ben did in a second, but from my at least experience in academia and in residency management, I've had about a decade and a half in residency leadership, both as an associate director and a program director. I've been an internal medicine clerkship director. Currently, I'm an associate professor of internal medicine at Western U College of Osteopathic Medicine in the Pacific. Well, my craziest story has nothing to do with internal medicine rotation. It is my surgery rotation where we had a necrotizing fasciitis come in. I was covering for another student because of the holiday, and that incision and drainage, the nice way to say it is just fragrance, not only the operating room, but the lockers, the hallway for quite some time. So that was a quite memorable nasal experience for me.
Yeah, so lesson of the day is surgery will give you crazy rotation stories.
Probably everyone will, or something memorable from everyone. I think we all have them, but I was trying to go extreme with that one, Ben.
Very true. Cool. So just a quick run through of what we're going to do here. We're going to hear from Seth from Dr. P about sort of his experience and some tips for you all on your IM rotations. He has sort of alluded to, and he'll talk about more, he has a ton of experience working with students and residents. And so he's seen this from sort of both sides of that divide, which I think is really helpful to hear about. I'll show you quickly some of the new stuff we've got going on in Sketchy IM. We have Q&A listed as a third piece there, but I encourage you to ask questions throughout. As questions come up, we'll kind of try and answer them if they fit in the flow, and we'll take some time periodically to answer any that have built up. And then Jane has an exciting giveaway for you all at the end.
So just a little bit about me. I am from the East Coast, from New York specifically. There's a beautiful shrunken pictures of Yonkers, which is my hometown, you would say. I went to undergrad up in Massachusetts, and instead of showing you a photo of my institution, that is an actual photo of my work desk during my undergrad. So for those of you that are not of my age, though, that is what our computers looked like back in the day. And then on top are what we called floppy disks. So yeah, that photo even bring back memories, and I was trying to look at it closely to recognize other things that I don't remember in the background. I took a gap year before medical school teaching anatomy and physiology to nurse practitioner students, also tutoring in the sciences at a local university in New York. And then that is me with more hair and a much younger age at my white coat ceremony. I went to medical school at Nova Southeastern University, which is in South Florida. And then I always thought I was going to do internal medicine. I was driven to internal medicine by my interest in gastroenterology. And whereas over time, my interest in gastroenterology faded, my interest in internal medicine remained the same. I did my residency training at the Texas Medical Center, specifically the University of Texas at Houston, now called McGovern Medical School, which is shown there in the Texas Medical Center. And did that for a few years, did chief residency year, and then moved to California and have lots of animals. So a little bit about internal medicine, and like Ben said, I've experienced with the residency side, the student side. Obviously, I'm focusing more now on the student side of your experience in internal medicine. What attracted me to it is the wide range of patients and the pathology that you'll see. That is why there is so much to learn on the rotation, because of the variety of patients, all the disease, different conditions you'll see. There are those core things like heart failure, pneumonia, DVT, PE that you'll see a lot of, but you'll also see a span of organ systems. And that is so great because it creates that learning opportunity for you during the rotation, and it teaches you how to study. If you study well and learn how to study effectively during internal medicine, it is a great way to study for your other rotations. In fact, surgery shelf, a lot of stuff from internal medicine on the surgery shelf. So internal medicine is a great starting point for all of that. And then there's a lot of material, and what you learned, a lot of your clinical stuff in second year of medical school is what you're going to be seeing to some degree, plus more in your internal medicine rotation. And the core of internal medicine, similar to other rotations, but internal medicine, we focus a lot on the details of a history, taking an accurate history, exam, doing an appropriate exam, interpreting the findings. Clinical reasoning is a big part of it, and then presentation skills as well. And importantly, these are great tools to learn for every single one of your rotations. The importance of the team and team-based care, and not forgetting that the patient is an active, actual, important member of the team and should be involved in decision-making for the team, is really important for internal medicine. So you will learn the dynamics of a team, how to work within your team, what your role is as a student, how you report to different supervisors, whether it's an intern or a resident or an attending. And the team really does work together. Rounding is a core thing on internal medicine. I've joked about my joke that I like to say is, if you like talking about a sodium for hours, welcome to internal medicine. So rounds can be long. And the thing about internal medicine is there's a variety of rounds depending on where you rotate, what style your attending has. You might do sit down or table rounds, bedside rounds, hallway rounds. Each attending likes to do it differently, but rounding on a lot of patients, talking about a lot of things, the complex interplay of conditions. Social issues in medicine, knowing about social determinants of health and how they influence diseases, and what you can do and if you're doing an inpatient rotation in the inpatient setting to help the social issues in medicine. And also, well, some of that's done in a primary care setting, but you have a key role in the inpatient setting. And then, like I said before, even though you have some metric earlier of second year education, there is a lot of information on internal medicine, so very robust from a knowledge standpoint. Some of these are very familiar graphics that float around that a lot of you might have seen already in medical school, but one is called the RHYME tool, which kind of it describes what your role is as a medical student, and how your role as a medical student changes throughout not only your years of training, but also even month to month, or depending on your clerkship specifically. Meaning reporter, interpreter, manager, educator. So theoretically, what is taught is that when you are a medical student, you start out as a reporter. Your goal is to collect data and report data. What I want to make you aware of is that on internal medicine, you have a role as a reporter, an interpreter, a manager, and an educator. And that role starts quickly and continues to evolve throughout your entire rotation. So yes, you have to know how to report data, report it correctly, gather it correctly, but you have to interpret it. You have to interpret everything from the history to the exam to the labs. You have to learn how to come up with management for your patient. And then educator is more an educator of yourself for knowledge gaps, but you're also educating your patients. So early on, the best skill to start to learn and to really conquer is a reporter, but you have to do a little bit of this during your rotation, and it will evolve during your rotation. And then there's the hierarchy of a ward team on internal medicine. And like I said earlier, the team is so important in internal medicine. And even though there is this hierarchy, depending where you do your rotation, location in the country is often a factor in that. Sometimes this hierarchy is not that clear. And I don't want to call your intern and resident colleagues, but a lot of times you are, by your attending, treated on the same level. And what that means from a medical student is, to a smaller, shorter degree, you have responsibilities that are very similar to interns and residents. You might have less patients, but some attendings expect your knowledge of what, how to approach them, to a degree that's appropriate to your level of learning, but in a similar way that they do to residents and even interns. And then, and your role as the reporter, interpreter, manager, and educator, the idea is, how do you do it effectively? How do you organize your thoughts and plan throughout the day, and then adapt to what your supervisor needs or asks? And that could be your intern, your resident, and or your attending.
I just want to quickly before we go on, I just want to echo the idea that this progression from reporter to interpreter to manager to educator isn't just something that you get sort of across the 4 years of med school, but is something that you traverse this terrain in each rotation. And so you start out very much on the R side, and hopefully you end up higher up this pathway. And I think one interesting thing about internal medicine that was certainly true for me, and I think is relatively common, is that you start higher up this pathway for IM than you do for almost any of the other specialties you do. So I started my year with OBGYN. I had no idea what I was doing, first because it was the beginning of the year, but also because you don't learn that content as much in the preclinical years. Whereas most of what you learn is relevant to medicine. And so the plus side is more already. The downside or the challenge is the expectations are higher, I think.
Exactly. And oh, sorry. And you bring up a fantastic point, Ben, is that, at the end of every rotation in your clerkships, you end the rotation, not a master of that subject, but you're kind of in the groove. You got it. You kind of figured out your rhyme and, where you stand in that. And then the next rotation, a lot of times you're starting at the beginning again because the expectations are different. And that is the greatest thing that all of you will take away from your third year, is learning that adaptability and resilience from rotation to rotation.
And that pattern repeats itself to a less extreme degree, but it certainly repeats definitely near intern year and, to some extent throughout residency, where you'll keep sort of cycling through different specialties.
Exactly.
Different
Exactly. And it'll continue on in all your training. Yeah, and I don't want to harp on this, but I just think it is something to be aware of, that one of the things that you are going to be looked at on your internal medicine rotation is how you present yourself. And what I mean by that is professionalism. Is one of the major things that your attending will look for, and it's another thing that patients will look up to and expect of you. And a lot of that shows your dedication to the rotation. A lot of that shows how you fit into the role as a team and as a learner. So you want to be on time. I mean, this goes without saying, but don't be the last to arrive for the rotation during the day, and don't be the first to leave. You want to keep within the hours that you need to function, but you don't want to show up late, and while the team is still working, you don't want to bounce. Instructions and attention to detail. I mean, the reason this is so important is not only in your future as a doctor, where attention to detail and your documentation and the paperwork you fill out is so important, but following instructions, attention to detail is a lot of what we do in internal medicine with data gathering and reporting it. So it makes a great impression overall if you follow site instructions, your school instructions from your attending. If they tell you to be at a certain place at a certain time, please be there. If they tell you to do something like call the lab and follow up on a lab result, do it. I mean, not only does reflect how you work within the team, but it shows how you follow direction and do the things a doctor needs to do. Goes without saying, dress appropriately, be honest. You are bound to make errors during your rotation. It's going to happen in every rotation. And when I say an error, I mean something like, what did you order that lab? What was the sodium? If you don't remember or you don't have access to it, don't make it up. Be honest and say, I don't have it. Let me look it up right now. This just reflects your moral compass. If you were supposed to follow up on something and you didn't, just be honest and say you didn't. that owning up to things that you can improve upon is a big portion of professionalism. Come prepared. If you have a reading assignment to do by your attending or supervisor, do it. And then remember, you are reflecting your medical school and reflecting medicine as a whole during your rotation.
You started with it. I want to end with it just to double emphasize it. Beyond, like, you should be the first person there. If you're not the first person there the first day, come earlier the second. That's, I think, one of the easiest ways to demonstrate to your team that you are like bought in. And I shouldn't, easy meaning conceptually easy. Waking up early is hard for some of us like me. But I think that if you are there first, your team sees that and knows that, and you can build that sort of reputation of, it's like the easiest way to present yourself as a hard worker.
Exactly. Definitely agree. So important, Ben, that it's even in the routine for the day. Oh, look at that. Look at that.
You're already doubling down.
Crystal ball working professional.
Yeah.
So the thing during every rotation and during something like internal medicine where the day is, it's pretty structured during your rotation. So you want to develop a routine for your internal medicine rotation. The routine will be obviously guided by the times that things are set on the rotation, like morning reports and conferences, but how you best function around that time and work your day around that time is very important to show your efficiency and to learn the best way possible and to provide the best care for your patients. So, some hints that I have are for you are, know the schedule for the week in advance. Just take a glance of it. Definitely know the schedule a little bit more in detail for a day or two in advance. You can structure your day. Make sure you get there on time to see your patients before whatever else is needed. So if there is a morning report that you have to be at 8 o'clock, that runs 8 to 9, and you round at 9 a.m., make sure you have enough time to do what you need to do before 8 a.m. There will be a little bit of time to discuss it with your team after that. So I won't say that usually rounds start at 9 exactly, maybe 9:30. We'll give a little more time for that. But, make sure you have enough time to do what you do. My helpful hint before you see your patient, before you even walk in and see your patient, is gather the data. Looking at the nursing notes, talking to the nurses, looking at the previous note to remind you, look at the labs that you have, look at if any consults happen, look what happened overnight, look at the vital signs. Though the key thing in medicine is those inform what you're going to do when you walk in the room with the patient. You don't want to walk in cold. So my example for that from a medical student, a third-year standpoint, that makes sense from a clinical reasoning standpoint is, if your patient had a fever overnight and you didn't know that by looking at the vitals when you walk in the room, compared to if you do know that when you walk in the room, you're going to ask them a completely different set of questions. So your data gathering informs how that encounter goes beyond the usual questions you ask and then exam that you do. So very, very important. And it's also important to discuss things with your team. Most attendings, we're not going to expect you as a third-year medical student to know the exact management for all of these complex conditions. A lot of the things that the attendings are going to be expecting of you is your team dynamic and how well you understand the plan of care of your patient as guided by your intern and your resident. And how much you read up and look on your own to add to the plan of care yourself. So before rounds, fitting in that time, make sure you have enough time to discuss it with your team and go into it in detail. I don't want any surprises on rounds. And quick story that I have, I like one of my early days, even as an attending, one of the first cases that happened was the medical student said, oh, there was an EKG that was done overnight because the patient had chest pain that I saw in the chart, and it shows all these ST elevations on it. And the intern and the resident were not aware that that was even done overnight, and nor did the student bring that up with the team. Thankfully, that was a false reading on the EKG that the machine did, but it just gives an example, like you want to be on the same page with things. And similarly too, that also goes for your supervisors. That same team, not that far after on rounds, I think it was like the next day, The intern reported a lab data that came back about a creatinine being elevated that just came in on the lab about a half hour earlier, and the student was busy seeing another patient. The student was not aware. So you want to work together to take care of your patients. Find time in the day to write your notes at the time that is appropriate. When you have downtime to write your notes, do it during the day. Learn from ancillary staff, learn from the nurses, speak to them, find out what's going on with your patients. And then as a medical student, you have the benefit of time. You have less patients throughout the day. Your interns and residents are seeing more patients than you are. They have a lot more phone calls and orders to put in. They have to run down and do things and on more patients than you do. So as a student, that benefit of time you have, use it to speak to the patients, use it to build that rapport, use it to do cool things involved with your patient, like going to procedures that they may have, speak to the families. And then I urge every student at some point, see your patients again in the afternoon, just to build that rapport and see if there's any clinical changes. You will learn the natural history of diseases and how they change in even a few hours, and how the management that you started in the morning has affected them even in the afternoon.
Yeah, to emphasize that last point, I think that was the single best thing that I sort of learned to do in my clinical year, was go back and talk to my patients again in the afternoon. It was a less pressured time than morning rounds, where you're trying to move quickly and you're sort of stressed because you have to present to the team. And oh God, like, how recently have I checked the labs? Did that creatinine come back? I don't, there's a lot going on in the morning. In the afternoon, you have more time just to talk to them, get to know them. You can often find out things that the team doesn't have time to. So I think that's a place where you can definitely add value. And then
Exactly.
On a more sort of, I don't know if it's cynical note or what, but seeing your patients again in the afternoon is, again, just a great way to demonstrate your sort of investment and engagement with their care. So it's sort of, the more interesting equivalent of showing up early.
Exactly. And take advantage of it. You don't have the inpatient setting, you don't have that longitudinal relationship long-term that you have outpatient, but you have that benefit of time with them that you don't have in the clinic setting during one encounter where it's so short. So in the hospital, not that you can spend the whole day there because you have to be wary of your own wellness. But that is what's so great. And that's why you're all becoming physicians, is that physician-patient relationship. And but better to do that than to just see your patient, make them feel better with that visit in the afternoon, that they're being cared for by you as a student. And most of my students, but even my greatest students, the patient views them almost more of the doctor than some other people on the team, because of the amount of time that they're able to spend with them. So take advantage of that. It's great. Presentation. So presentation, this will differ from attending to attending. And I'm not even talking about presentation from one rotation in surgery to medicine. Why is surgery always the barometer compared to internal medicine, Ben? I don't know, but we a little bit different. Let's say neuro to internal medicine. But even on internal medicine, from attending to attending, it's going to change. And some attendings, even in internal medicine, will want it to be very concise. Some will want it to be very detailed. So it will be okay with you if you have an orientation with your attending to ask them, how would you like initial histories presented? How would you like SOAP notes presented, if you have that time to do it? Sometimes, and I'll say oftentimes, you won't, and you just have to dive in and give it your best shot based on what you know and what maybe your previous internal medicine attending wanted. And then the key thing I want to let you know is be adaptable, because that attending might say, no, I don't want all vitals. I just want the abnormal vitals. I don't want all labs. I just want a change in labs. One of the big differences that I have seen throughout my years is some internal medicine attendings want the emergency room course in the history of present illness. Others do not want it at all. So you will flub on this. I've been there. I've done it. I've seen my best students have done that. But what my best students do is they learn to adapt, and they've learned to adapt to me and what I want from my presentation. I like all labs read to me, all basic labs, because I like to interpret labs and talk about how they relate to care. So at least a CBC and CMP from me, I want read every day. It doesn't take that long, and it's so much we can talk about. Other attendings don't want it, and there's no right or wrong way. So the point in presentation is there's no magic key to it. It's do what you know best that you learned in school, practice, 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 and adapt to what they want.
We got a great question here about your last slide. So you mentioned talking to ancillary staff and sort of figuring out the added information that they can provide about the patient's course. What's a good way to break the ice with nursing staff to get them to want to be on your team and to help you when you're a student?
They are your best friends in the hospital. Be courteous. Keep their areas clean if you're around the areas. Respect their instructions, respect their space. And the other thing too is the thing is they know how valuable they are in the care of the patient because they are. And as a student, they are expecting that. So the way I break the ice, or I was to tell my students break the ice, is find the nurse and just introduce yourself. Hi, I am student Dr. Politano. I'm taking care of Mr. Mueller in room number 25. I just want to ask you, how's he doing? And then the other thing to really discuss with ancillary staff that's important is get their input on things. Like, oh, well, have you noticed any changes in him? What do you think is going on? What, the nurses have been there and done that. They are so valuable. They spend so much time with their patients. They have so much insight into things. Now, you have to always analyze it, and you always have to use your clinical judgment and your team's clinical judgment, but you want to get their input and their advice on things to do. And this is how you should introduce to other members of the care team, physical therapists, as other healthcare providers in the hospital, be around them as they're working with the patient, get their input. They provide, oh, this patient is not safe to go home. They can't walk so much. Well, what do they need to get there? What devices do they need? That is the great thing about internal medicine. Like how I mentioned, the team takes care of the patient. It's beyond your team. It's social workers, care coordinators, physical therapists, nurses. Involve them in the care, show your interest. That I've had many of them even come up to me and talk to me about my greatest medical students and how involved they are and interested they are in the care plan of the patients. And on the other side, if you are rude or disrespectful, that becomes known to us very easily. So, not that I have to tell you not to do that, but just be wary. And we all have bad days. Read the room. If a nurse is very stressed out and doesn't have time to talk to you because they're busy, they have to get blood from the blood bank quickly and transfuse it on another patient. You can't interrupt what they're doing, so you have to be mindful of how hard they're working and what they have to do for patients as well.
Yeah, I think be humble. I think someday you're going to be the best clinical thinker around, and you will be the one ultimately sort of responsible for the patient's care. But today you're just a baby med student, and they have years or decades more clinical experience than you do. And so, I think keep that in mind when you're sort of introducing yourself and doing all the things that Seth said.
That was me in the ICU, Ben. But ICU, I started my internship in the ICU. Those ICU nurses, they are superstars. And, Dr. Politano, we're maxed out on this presser. What do you want to do? Well, what do you usually do? And that goes from the junior level to all of you as medical students. Ask the nurses. They have so much experience.
ICU nurses are truly special. Like, just ask them what to do. They'll just tell you the right answer.
So this is one thing I tell my students as they start the rotation. When I'm doing my orientation with them is come strong, even if you come wrong. So you are going to be asked a lot of questions on your internal medicine rotation. Like I said before, it's so much knowledge, so much information, so many diseases. I'm going to go out on a limb and say, you're not going to know, even the best of you are not going to know the answer to every question, and that is okay. You want to take as much of an educated guess as you can as possible. Just don't throw something out there. attending should be giving you around 10 seconds to answer a question, unless rounds have to go a little quicker, but you should think about it a little bit before answer. Try to take an educated guess. The best way we as educators can make you better clinical thinkers is by taking educated guesses and finding out where the lesion is in your thought process. It's not as clear cut as you're right, you're wrong. Those us educators will say, well, why did you come to that conclusion? And we'll do your reasoning, whether it's your basis, what you learned in the first 2 years on physiology and how you're applying physiology to the case. It's only when we can find what that issue was in your thinking that we can correct it to make you a better learner. Now, there are times that you will have absolutely no idea. They're going to ask you about a disease you've never heard of. They're going to ask you about a medication that is right off the mark, right, just came approved by the FDA that you never learned about in med school. If you don't know, get used to saying, I don't know. And the next thing to follow when you say you don't know is, I don't know, but I will look it up and let you know tomorrow. That shows initiative. That shows that you're always trying to learn and improve. And that shows because it's around not only your the questions are not only around your patient, but maybe even other patients on the team, how invested you are in knowing that all you need to know about your patients to provide the best care possible.
Yeah, I would say that I don't know, but I'll look it up and let you know tomorrow is like, that's table stakes. Like, if you say I don't know, you almost must follow it.
You must.
But I will look it up.
You must. And I truly reserve that for those times when you have no clue what the answer is. Otherwise, try to take your best educated guess. Really give it a go.
I think you may actually sort of allude to this or touch on this slide, but
Yeah.
Angela asked, is it appropriate or okay to offer treating the patient with OMT if they can tolerate it and there are no contraindications? And I might expand that to just like, when is it okay for the student to do stuff?
So in general, and I touch on this a little bit later with just kind of like even just responses to patients. But you know, I'll answer that two ways. One, I'll answer that question directly and then kind of general approach. So from an OMT standpoint, I'm a DO, as you can see. I don't do much manip medicine. I use my osteopathic diagnostic skills to think about things that are beyond other, you know, and I think of MSK issues and how they might influence patient care. And I rely on others to provide that therapy. You know, stay in your lane, know what you know, and do what you do best. But when you're doing OMT, I will say one thing is it depends on the rotation and the rotation site and who your attending is. So if you are an osteopathic medical student and you are on a rotation with an attending that is an osteopath, that is something to do the groundwork with and ask. Ask your attending, you know, I really like to do OMT. If I have a patient that has somatic dysfunction, do you want me to provide it myself? Do you want me to pass it by you? You know, even in med school, when TAs or fellows in the OMT lab find a dysfunction, sometimes you have to go to the attending to check to make sure it's there. So find out from your attending what they want. You know, but with that said, my general approach is if there's no harm and it's okay, do it. You know, so from an OMT standpoint, soft tissue techniques, fascial release, muscle energy, all of those probably pretty good for your patient. From an osteopathic standpoint, really quickly, sometimes I'll say though, not all dysfunction has to be treated in the hospital if it's chronic dysfunction. Sometimes those are best suited for outpatient treatment. If you have an MD attending and you are a DO, you might have to explain. You might have to explain a little bit of what osteopathy is, and I don't want to say you have to convince them, but educate them. I mean, I worked in my residency with a lot of MD attendings that were very open to me explaining what my diagnosis was for them, and you know the little things I could do at that time to help them with my experience. But touching on that a little bit more, Ben, you're like, what can you do with your patients? I mean, you know, as a student, what are you doing? I mean, you're expected to do a history, you're expected to do a physical exam. If you're doing a physical exam that is a sensitive physical exam, always make sure you have a chaperone in the room. So that includes any pelvic genital breast exam, make sure that there is some chaperone in the room with you. You do not want to do procedures on your own ever in the room. I would even argue things like wound care changes, dressing changes, do not touch those. Those are best led. You can make a lot of errors in doing that unless you know what you're doing. The biggest thing that I find out of all those that students tend to run in, that tends to be an issue later on, is what I have even here on the slide was about making promises and being cautious with your answers. Students will be asked by patients and families, "Can I go home today?" And then they will say, "Yes." Something as innocent as, "Yes, I think you can go home today." Students will hang their hat on that. I mean, patients will really like hang their hat on that. And then when you go into round, "But he told me I can go, that I can go home today," or "She told me that I can be discharged tomorrow." So, you have to have that delicate balance with patients and families of reiterating what your team has already discussed as the plan, as you as the communicator, you might have already rounded and discussed, "Oh, this patient might be discharged tomorrow if these things happen." You might have discussed on rounds that they need a couple of days there. So those are the things you can communicate. If there's questions that are asking you about like, "Well, what does this medication do?" or "Explain more about this disease." Yes, please do that. But make sure you've cleared it by your team first, some of these things. And then with that said too, other sensitive things like diagnoses that are a little bit harder for patients to take. If you're not experienced enough, don't do that on your own. Discussing things like end of life care, sensitive issues with code status. There were things as a student, not only from what can you do, but what you can discuss that you should be a little bit wary of. And then, on this slide, besides that, I just want to, play well with others. We already talked about that, Ben. Another big thing about a team is, the best students, depending on the rotation and the site that you're at, are really proactive and true members of the team. So what that means is you are taking care of your patients and you know everything about your patients and you are as active as you can on your patients, but you also help out the team with other patients. So, if something needs to be done on the team, the great way that your residents and interns will say fantastic things about you to the attending is you offer to help them out. "Oh, do you need me to wheel down Mr. Smith to the discharge area because it's taking too long? I'll help you with that. Oh, do you need that, if the procedure is being done and there's a sample that has to be run to the lab right away, even if it isn't your patient, and you know where their lab is and you feel confident, run it down to the lab, make sure there's a label on it." But on your own patients, the thing I loved about internal medicine, and I try to get my students to love about it, is how you are being the mini doctor for your patients. You are expected to know everything about them. You are expected to do full plan of care. So what Ben and I were talking about earlier in talking to ancillary staff, it goes beyond that. Your patient is going for a colonoscopy, go to that colonoscopy. If your patient got a bone marrow biopsy, run down to the lab, discuss with the heme pathologist what the results are. It's a great learning opportunity in everything in medicine. Know about subtle changes in your patient, know what happened to them overnight. You are responsible for all of their care as a student. You can't put in orders, you can't do procedures at the bedside, but beyond that, you are a mini intern as a third year. You're a mini intern as a fourth year, you're an intern as an intern. So it's a great protected way to do it with a small patient load. And the other thing is, don't be afraid to ask for ways that you can improve. Now, don't be, my advice, don't be the student that every day, "How am I doing? What am I doing? What can I do to get better?" One way is if you get feedback from anyone, attendings, residents, interns, don't take it as an insult. Take it as they are trying to improve you. They are trying to make you better. They are trying to make you better to make patient care better. So if you get feedback from your supervisors, take it in a way that you can try to improve to get better. oh, I noticed that you didn't gather the labs before rounds. Make sure you gather those labs before rounds. Yes, you did something you need to improve upon. Show that you can make improvement on those things. Your attending might say you didn't do the pulmonary exam completely and accurately. You missed this on exam. Find a way to get better on accuracy of your physical exam skills and interpretation of physical exam skills. I would say that after your first day with presentations, it's always good to ask how you presented and any suggestions. That first day, you are fully allowed to do that. I say like about a week into your rotation, just ask for general feedback. Hi, Dr. P, just want to know, I just want, is there anything I can improve upon? And then turn it positive. Is there anything that I'm doing that you really, that you think I'm doing well? And then the idea is improve upon that. So we are there to make you better, ask for how to get better. So I say at the 1 week mark, the mid rotation mark, and then your attending is required to give you feedback at the end.
Few things just to add there. One is,
Yeah.
Seth, you presented that feedback very nicely. Not everybody's going to do that way. So I think your point about don't be insulted by the feedback holds true, even if the feedback feels very insulting. Try and have the thickest skin you can and seek out the nugget of improvement in it, even if it's incredibly mean-spirited, which it may be. The other thing I would say is it's sort of easy to respond to feedback when you receive specific feedback, but like you were saying, it's really annoying to the team if your question every day is basically like, am I going to get honors? Am I going to get honors? But if you have specific things that you feel like you want to improve on or want to ask about, I think that's a great way to get feedback if you feel like you're not being given it sort of automatically. So ask about specific things you can improve on rather than just like, how am I doing?
Yeah, perfect. And to that extent too, Ben, if you're given feedback on something to improve that either you asked for or is given to you and you don't know how to do it, ask for help. And even if it's from the attending, ask the resident, hey, Dr. P said I need to improve upon this. Do you have any hints or suggestions? Definitely. And then yeah, if you get feedback that's a little more pointed, don't take it personally. Get past that, have that thick skin, and find that element of that where there is truth that you can get better. And your crystal ball is working with my slides again. You mentioned about like, how do I get honors? How do I get honors? Well, this is how my students get honors. Look at that little fluff ball with the A+. How cute. So this is just for, and look, there's no formula to this even from me. Every attending is different, but I wanted to give all you insight on how my students get honors on their IM rotation. Being professional, being on time, speaking with respect to members of the team, and even just as important, to patients and families. I want you to be involved in the team, help out the team. When another person is presenting, whether it's another student or intern or resident, be involved, listen. Don't ask a million questions as they're presenting and interrupt them. That's not the idea, but show interest in everything about the team and help out the team. Like I said earlier, that active role with patients, I entrust my students to be full care providers in the hospital to the best of their abilities and limitations, but be that provider for your patients. Show your eagerness to learn. And when you're eager to learn, what I mean by that is if you're asked to do something to read up on it. And in that said too, make sure that you are reading on your patients and you're showing that you're reading on your patients by improving your plan of care the next day. If you admitted somebody with 5 medical conditions on day A, and now you're presenting them on day B, integrate what you learned into your presentation. It'll make you even understand the disease and disease process even more. And it'll show me as an attending that you care enough about your patients that you're reading up on them to provide them the best care possible. And then in the hospital, I stress a lot, like in the hospital, there are a lot of things to look after on your patients, and it is their social issues, it is their dispo planning. So look, that whole element of patient care and that holistic care, goes beyond their labs or their medical conditions. It goes to where they're gonna go when they leave the hospital and how we're gonna get them there. And I had it on the previous slide. My thing I say is your patients are humans both inside the hospital. Your patients are humans outside the hospital. So before they leave the hospital, we have to make sure they're able to do normal human functions: walk, talk, eat, drink, poo, pee. Make sure they can do that. I've had patients where they're ready to be discharged, and then it's like they haven't walked in a week. That reflects badly that you haven't looked into that. And then the key thing is, like I said, I want to see during my rotation that you as a student are improving. I'm not making sure that you're coming in a genius. That's not the point. I want to make sure that you take that feedback I give you to improve, and then you're always learning and you're always trying to improve during the rotation. And that is how you're reflecting your medical knowledge to me, is how you improve on things. The first day you're admitting heart failure, you might not know heart failure guidelines. That is okay. But by the fifth patient we have with heart failure guidelines, I'm expecting you to kind of grasp it and know it a little bit better. So that's what I'm looking for honors, is that improvement.
Yeah, I think we talked a lot about feedback and some of the other stuff, that transition up the rhyme slope or ladder or whatever. I think that converting on all that is extremely important. So if you get feedback or you ask, especially if you ask for feedback and then somebody gives you some advice, you got to go do that thing.
Exactly. And that's what I look for. Thank you, Ben. And yeah, I'm kind of doing my own feedback, my own sandwich, so to speak. So I started with the fact that there's a lot of pathology and a lot of things to know on internal medicine. And I want to stress that this rotation is a learning opportunity for you. And you're going to gain so much about how to be a clinician from this rotation, and thought process and clinical reasoning. But the thing I tell all my learners is that you have to retain some of your habits from the first 2 years. So just because you are entering the clinical years doesn't mean the studying ends. So you have to learn two types of learning on the rotation. One is point of care learning, and one is just to study. So point of care learning, we use that as a medical terminology, kind of especially more in the outpatient setting. But what that means is, if you have a patient that comes in with a condition and you have to present it a little bit later in that day, look it up. If they're on a medication you haven't heard of before, look it up as you're writing your note. So you want to learn as you're getting new data and new information. And then when you go home for the day, please study, study, study. You have to study during your internal medicine rotation. You will see a great variety of pathology, but you will not see it all, and you have to know it for your shelf and or COMAT exams. So study, study, study. And then, like I said earlier, when I say show off, I don't mean like, oh, I read 20 hours last night, or I studied Sketchy for 5 hours last night, and this is what I learned. No, you want to show that you learn things by integrating it in your plan of care. So for heart failure, I'm going to do evidence-based guidelines by treating with this, by treating with this, by treating with this. So you're studying not only for yourself, but you're studying for patient care, and you're studying also to show your attending how involved you are in your patients.
And now, look, your crystal ball is fully operational too. So speaking of study, let's talk a little bit about Sketchy. I know there's some questions still left, and we'll get to those. But I want to quickly talk about Sketchy IM and some of the new stuff that we've got going on. So our IM course covers essentially the full spectrum of what you would expect to find on the rotation and on the shelf and on step 2 for IM. And again, as we've at least sort of alluded to throughout this conversation, IM underpins basically everything. So on your surgery shelf, you're going to find it's a lot of IM. On your, well, PEDS shelf might be a little different, but on many of your shelf exams, you're going to find that there's a lot of IM involved. So like I said, we cover the full gamut. Seth has had the privilege or the pain of watching I think every single one of these videos or close to it. And
everyone then.
Yeah. And I want to take you actually through our mobile app. So let me see if I can figure out how to how to do this quickly. So this is pretty exciting for us. This is a new thing. Let's see if you can see this. Okay, cool. So this is Sketchy on my iPhone running live right now. So you can see if you click into IM, we have, look, we're trying to make him famous on the we're trying to make him famous on the internet. There's Seth. He gives a little bit of an intro and an overview of what you're going to learn in the course. We take you through some pearls, so basic stuff like how to read a chest x-ray, and then we sort of go into the different specialties or areas of study that you'd expect to encounter on your rotation. If you've been using Sketchy Clinical, you'll know that a lot of it got updated earlier in the summer, but IM didn't get an update. And so this week on Tuesday, we launched our first batch of new content for IM in rheumatology and a few other scattered lessons. So I just want to take you through one of those room lessons. You can see sort of the breadth of content we've got here. I want to take you through one of these room lessons very quickly just to show you what the new experience is like. So many of the new lessons start with the sort of same style of sketchy video that you know and love. I don't know if this sound is going to come through here, but we can at least...
Hey, it's Ben.
Oh.
You know, they say the best part of a vacation is the anticipation before you even go. But in my opinion, the best part is boring all of your friends and family to tears, showing them pictures of your escapades. Anyway, hopefully we won't bore you to tears in this sketch, where we'll be covering rheumatoid arthritis or...
So, you know, same style sketchy, we bring in symbols, we tell you sort of how the thing works. You can go through the symbol explorer and tap through each of these things after the fact. The new thing is that we have these additional learning cards after. And the idea here is that there's a ton of content to know for any individual condition in IM. And we want to balance getting you the most memorable stuff in the most memorable way and still having this sort of long tail of relevant content available to you. So we take you through these learning cards. We bring back symbols from the videos or other symbols from Sketchy that you've sort of used in the past. You know, you'll see these symbols are in the sketch, and you'll also notice some sort of floppy heart balloons or things about heart failure that you've seen before. We have tables, we have anatomy in these lessons where it's relevant. Excitingly for us, we have these clinical pearls from Seth, adding sort of extra little tidbits that he's seen students struggle with or things that he finds that often trip people up. You can sort of quickly jump around through the lesson and see the various parts. Most of our lessons at this point have a cram card. So you're about to see a patient with rheumatoid arthritis, or you're about to go into your medicine shelf. What are the things that you really just got to remember about this quickly? And then every lesson has a set of quiz questions. Again, if you've been using Sketchy over the past year, you've seen these lesson quiz questions. These aren't UWorld, what am I supposed to call it? UEarth questions. They're not board style. They're meant to be quick. Was I awake while I was going through this lesson? Was I paying attention? Style questions, just to make sure you've got sort of the basics of the content down. So they're not supposed to stress you out or be too difficult. Again, this is something that is meant to fit into your busy days on the wards. So 5 of these per lesson, and then you're done and you're out of the lesson and you can sort of move on to the next one. Again, this is something that you can do while your resident like goes into the bathroom. You know, if you remember, unlike me, many times not to follow them in, or when you're at home at night studying for the next day, look up a condition that you saw in a patient that day, or look up something that you didn't see and aren't expecting to because you're not going to do that particular subspecialty on your rotation. We had a question from Jessica, I think. Will any of the clinical lessons that are currently just written lessons be turned into videos? And so not every new lesson has an associated Sketchy video. Some of them are just those learning cards. There's an implication from us that that content is either sort of less high yield or less difficult, so that the learning cards we think are sufficient. But we definitely want to hear, if you're looking at a topic and you're like, man, I'd really like a video here, please tell us. You can submit feedback in the app. There's a little like or dislike button on every single card. Email us, ben@sketchy.com, very easy. We definitely want to hear from you about sort of how you're liking the cards, where you feel like a video would be helpful. You know, we've tried to thread that balance. We want to get you the information as efficiently and comprehensively as possible, while still making it not suck to learn. I'm gonna turn off my iPhone here so I can get rid of that.
In the chat, Ben. Oh, you're still going.
Yeah, so just really quickly, since nobody does just an IM notation, we've got all the other stuff too. Again, a Sketchy subscription comes with both preclinical and clinical, so you can always go back and look at micro and farm. We've got all the rotations covered at this point. Jen, actually, if you go back one slide, I didn't talk about this yet, but we'll be adding a bunch more IM content next month and the month after across all those sort of subspecialties that I've listed there. And we'll also be adding a bunch of new surgery content in the next couple of months. If you haven't done surgery yet, something to look forward to. If you have done surgery, I would love to talk to you. Email me, ben@sketchy.com. What about Android? We would love to get this onto Android. I don't want to give you a release date or anything yet, but we are certainly mindful that there are not just Apple people in the world. Cool. I know there are a couple other questions that we didn't get to, so I want to try and talk about them now. Seth, I don't know if you sort of pre-rounded on any of the questions already, but
I've been pre-rounding.
Amazing.
So yeah, really quickly, there was a question about social, can we work with social workers to see what social networks? Yes, please. That there's so much to learn on rotation. Speak to social workers, find out the different locations that patients can go to after discharge besides home and what those mean. What's the difference between a boarding care and a SNF and an LTAC? Also, what resources there are to help your patients outside of the hospital with food insecurity, with getting disability paperwork. I mean, yes, learn from your social workers. That it's another great thing to learn about the rotation. And then I just had a question, Ben, about how Sketchy can be used for internal medicine residency and boards. I mean, I will say this. I think especially as you start intern year, it's a great review. It'll help remind you of clinical conditions, diagnostic criteria, or treatment. So, but for those of you in internal medicine residency for board prep, what Sketchy content has to be supplemented by other things. And I will say that's mostly because by the time you use Sketchy and boards happens, there's so many new guidelines coming out and studies that come out that you have to be aware of, from big picture that you need to know. And then simply said, I mean, internal medicine is so complicated and in depth from boards compared to what Sketchy has, which is very student focused. So I say early in internal medicine residency, Sketchy is great for review and reinforcing, and even later on to remind you of diseases in the way that you learned it from the Sketchy way to help you remember it. It's great, but you have to do more in addition to it.
Yeah, I'd add also, I think there are some aspects that in some ways, funnily enough, almost the particular specialty becomes less useful. The particular specialty course in Sketchy becomes less useful sort of the more advanced you get. But some of the other content, micro isn't going to change a ton. Farm isn't going to change a ton. And so some of that review, especially if it's something you used as a med student and it's sort of there in your head, like it just sits in my brain all day, no matter how hard I try to get it out. That stuff can be really helpful.
Definitely.
Medical that would be an amazing sketch. It's just a sketch on medical abbreviations because yeah, oh boy, there are a lot.
I would, what I would look up for medical abbreviations to start on one thing from an internal medicine rotation standpoint. I would look up Joint Commission, JACO, approved abbreviations. Because in the hospital setting, there are abbreviations that cannot be used and there are abbreviations that can be used. So that's one good resource to start. Our ophthalmology friends have a lot of abbreviations that they use that I still can't figure out to this day. So I always have to look them up and Google them. That I definitely need a sketch for, Ben.
Yeah, Jen, we should do a blog post on this. We'll credit Alyssa for the idea. Alyssa sent it to host and panelists. Nobody knows what we're talking about. Alyssa. Cool. Sorry, I know we're a few minutes over. I do want to get to the giveaway here.
Yes.
But if you ask
Yeah.
more questions, we will continue to answer. I will stick around to answer.
Yep. So I actually pulled a random number generator behind the scenes, and we have the 9th person out of the 70 something who joined us today. And the winner of our 6-month free Sketchy subscription is Ellis Morgan from LMU. If you're still with us, let us know in the chat. Ellis Morgan. Oh, hi. Congratulations. I will be in contact with you regarding the 6-month, and also want to do a shout out about our back to school sale for those who did not win. We are running our biggest sale of the year, so take advantage. It does end at the end of this month. Cool. We can go back to Q&A.
Awesome. Let me scroll back. I think there was one I missed that I wanted to answer. Oh yeah. What if other team members are not doing the same or opposite of you? And I think this was back when you were talking about professionalism and sort of engagement, behavior, feedback, etc. I'll say for my part, I'm curious to hear your point of view. And I think I said this on the PEDS webinar a couple months ago. So if you came to that, sorry for the duplicate advice. But the one thing you truly have control over during your clinical year is yourself. And so how you respond to a situation, and how you maintain a good attitude, continue to stay engaged. You know, there's always going to be other students doing other student things. And so the one sort of factor that you can control is how you respond to all of that.
Ditto. You know, your job as a student isn't, you're not there to correct other students on the rotation and make them better. You know, when you are a supervisory student or an intern or a resident, there are things you do to make learners better. And, you know, with modeling, not only how you model behavior, but also giving them hints, telling them ways to improve. But for those of you that are starting on your internal medicine rotation, you're not there to correct other students or improve them. You're there to correct yourself and make yourself be the best you can be and improve yourself. Now with that said, you should help others out. So once again, helping your team involves helping them too. So if another student needs help with something like, oh, hey, can you come down to the lab with me and help me with this? Or, you know, I'm about to, you know, can you help me find this chart? I've been looking for it. I can't seem to find it. Yeah, so, you know, be a helpful member of the team. But if they're not acting to professional standards, that's not really your goal. Now, the other way, help each other too. If you know, if you have downtime and you're hanging out with each other, is, you know, same way if you form study groups during med school, talk about your patients with your colleagues in your medical school class. You know, teach them what you reviewed, work together to learn about your patients. So from that regards, that's how you help out other members of the team. Becomes a little bit more of a specific sensitive topic with if there's issues with your, you know, with your intern or your resident, and if they're not behaving professionally to you, you know, then, you know, I'll say what I expect, that if a student is being mistreated by their interns or residents, they should talk to their attending, but you should not try to correct them yourself. That should go to your attending.
100%. One just extra plug here. Sketchy we're a small outfit. We've got a lot of former med students here. We really, really care about making this extremely useful to you. So I've already dropped my email in the chat once. I mentioned the feedback thing, but genuinely, as you're using this content, we want to hear about how it's helping you, where it's not as helpful, what we can do to make it more useful to you as you're going through the year. So by all means, reach out, drop comments through the app or the website, send our support line an email. We want to hear from you. Putting my email in again, just in case.
If they have questions for me, Ben, you can send those my way, I guess, too.
Yeah, always happy
Yeah.
to forward stuff to Dr. B.
Thank you.
Awesome. Looks like no more questions. So thank you all so much again for coming out, especially during this incredibly busy rotation. I know a lot of you are on. Really, really appreciate it, and look forward to hearing from you about the course, and look forward to you using it.
Thank you all for attending.
Good night, everybody.